I see everybody joining.
Welcome.
Welcome everyone who's joining. We're just going to give everybody a couple minutes to get on, and then we will get started with Dr. Ta. Let me make this bigger. There we go. And just a reminder to everyone who is already in to utilize the Q&A button at the bottom of the webinar to put any questions in that we'll be able to get to at the end. So you'll be able to use that to submit your questions. Okay, we'll give it one more minute and then I'll get started.
I think you can go ahead. It's all on the record.
Okay, all right, perfect. All right, so welcome everybody on this Friday, almost afternoon, I guess, depending on where you are. Our webinar today is with Dr. Hue Ta from SCU on diet and nutrition for type 2 diabetes in adults. And we are just gonna get started with a couple slides that we're gonna run through before she starts her presentation. So this is just a quick timeline that everyone can kind of take a deeper look at after the webinar, but something to note here is that the Academy of Integrative Health and Medicine was launched in 2014, which makes next year, 2024, our 10-year anniversary, which is pretty exciting. So throughout our conference this year and leading into the new year next year, we'll have some really exciting new announcements and developments and events that we're going to be hosting that everyone in the community will have a chance to take part in. So that's really exciting. And then this slide just really kind of demonstrates the fact that AIHM is really a global community. We are made up of individual members, organizational members, different agencies and researchers. We're a part of the greater industry as well as different sponsors throughout the year and our conference. So this is a unique opportunity or offering we have this year for our October cohort for our fellowship. If you apply by June 18th, which is coming up, it's in about 2 weeks, and pay your admissions fee by the 4th of July, your ticket this year to the 2023 conference is on us. So you'll get free admission to the conference when you join the October cohort. And then that cohort begins on October 2nd. You can go ahead, Jess. So I'm going to welcome our guest today, who's going to be hosting our webinar, Dr. Hue Ta. Dr. Ta is a doctor of physical therapy, as well as a recent doctor of acupuncture and Chinese medicine graduate from SCU. She received her master's of physical therapy from Louisiana State University Health Sciences in New Orleans in 2005, and her post-professional doctor of physical therapy from Utica College in New York in 2015. Dr. Ta has practiced physical therapy for over 16 years in multiple settings, ranging from acute hospital settings to home health care. Currently, Dr. Ta is an adjunct faculty at SCU and practices acupuncture and physical therapy in private setting, focusing on longevity and preventative care. She also works with infants and toddlers overcoming gross developmental delays. So we are honored to have her presenting with us, and I will turn this over to you, Dr. Ta.
Thank you very much. All right. All right. So we're going to be talking about diet and nutrition specifically for type 2 diabetes in adults, and this is going to be quite brief. We only have a really short amount of time to talk about these things. So we're just going to briefly review the background information of the biomedical and TCM perspective, and comb through a handful of the latest systematic reviews, meta-analysis covering diet and nutrition. So we know, according to Western medicine, diabetes is a chronic disease that's defined as a metabolic disorder characterized by hyperglycemia, resulting from either deficiency in insulin secretion or the action of insulin. There are three main types, but we'll be focusing on type 2. Type 2 diabetes accounts for 90 to 95% of all diabetes, and you'll see that in the next slide. The worldwide prevalence is estimated to affect approximately 700 million individuals by the year 2045. So yeah, this is just a nice graph from the CDC, just showing you the prevalence and the increase in prevalence from 2001 all the way to 2020. That's why it's so important for us to look at this. According to the ADA, the annual cost of diagnosed diabetes in America is currently $327 billion. That means 1 in every 7 healthcare dollar is actually spent on treating diabetes and its complications. Type 2 diabetes is by far the most common type of diabetes. It is associated with old age, obesity, family history, physical inactivity, and ethnicity, though the vast majority are overweight. So in type 2 diabetes, insulin secretion is inadequate because patients have developed resistance to insulin. However, the pathogenesis of diabetes is complex and incompletely understood. Although insulin resistance is characteristic in people with type 2 diabetes and those at risk of it, evidence also exists for beta cell dysfunction and impaired insulin secretion that progresses over time. Type 2 diabetes may also arise from other diseases or due to use of certain drugs, such as glucocorticoids, thiazide diuretics, atypical antipsychotics. For patients with type 2 diabetes, they can present with symptomatic hyperglycemia, but typically they're often asymptomatic. Therefore, diagnosis may be delayed for many years if routine screening is not done. Early symptoms may include polydipsia, polyphagia, and polyuria. Years of poorly controlled hyperglycemia can lead to multiple, primarily vascular complications that affect small vessels, large vessels, or both. Immune dysfunction is another major complication. So these are just some things that we want to see, and we'll see if we can help to prevent. So diagnosis is based on clinical features when present and measurement of blood glucose levels. In practice, diabetes or impaired fasting glucose regulation is often diagnosed using random measures of plasma glucose or of HbA1c. A random glucose value of greater than 200 may be diagnostic, but values can be affected by recent meals and must be confirmed by repeat testing. Testing twice may not be necessary if there is a presence of symptoms of diabetes. So just something to take note. So key elements of treatment in patients are patient education, diet, which is the one that we're going to be focusing on, exercise, weight loss, and monitoring of blood glucose controls. Patients with type 2 diabetes and mildly elevated plasma glucose should be prescribed a trial of diet and exercise, followed by a non-insulin anti-hyperglycemia drug, often metformin, if lifestyle changes are insufficient. Most algorithms for type 2 diabetes do not recommend treatment escalation until HbA1c fails to reach the recommended target of 7% within approximately 3 months of any treatment regimen. Clinical inertia and/or poor adherence to therapy contribute to patients not reaching their glycemic targets when managed according to this paradigm. Possible reasons include complexity of treatment and guidelines, psychosocial stress, intolerance, polypharmacy, and adverse effects, to name a few. So I want to just talk a little bit more about the TCM perspective. So typically in practice, many patients presenting to the TCM clinic are already diagnosed, medicated, and at least partly managed. They present because the side effects of the medications can sometimes be troublesome and are not achieving good blood glucose control or experiencing complications. So from the perspective of TCM, diabetes is known as Hue Ta, literally translated as wasting and thirsting. Hue refers to excessive consumption of fluids. Ka refers to unrelieved thirst after drinking. So you can see the three key signs also here in TCM, which is your polyuria, polyphagia, and polydipsia. So just a little bit on the historical text. Diabetes was first described in the Huangdi Neijing. This is one of the very first classical texts in Chinese medicine, written about 2,000 years ago. As centuries have passed, there have been many refinements, as you can see here, in the studies of disease, but it was not until the Song Dynasty did the medical scholars classify the disease as they do today. Just a little fun timeline. So in TCM, the causes of Hue Ta are typically improper diet, emotional trauma, or exhaustion or overexertion. There are typically two basic courses of disease. First is the primary yin deficiency resulting in dry heat accumulation. And then secondly, the damage to qi yin and yin yang emerges in prolonged cases. So it just depends on if it's more of an acute or chronic condition. So in early type 2 diabetes is in TCM, it's associated with spleen qi deficiency or qi constraint, damp heat, or phlegm. Those are some of the pathogens related from a TCM perspective. The more protracted the condition, the more kidneys are weakened and yin depleted. And this will result into the most common chronic pattern, which is qi and yin deficiency. So then that can affect the mechanism of blood glucose in the body. So here you can see from a TCM perspective, the various types and patterns. So there are three differentiated subtypes. So there's upper Hue Ta, which is represented by heat in the lungs, like dryness and heat injuring the body fluids. There's middle Hue Ta, which is due to excessive heat in the spleen and the stomach. And this is not only just talking about the organs, but we're also talking about the theory of the organs and the mechanisms of the meridians and the channels in the body. Lower Hue Ta can be present as either a kidney yin deficiency or yin and yang deficiency. So you can see the similarities in the symptoms. So polydipsia more related to upper Hue Ta, polyphagia more with middle Hue Ta, and lower Hue Ta with polyuria. So the advantages of complementary and integrative health is seen here. According to research, approximately 70% of Americans with diabetes have used complementary and integrative health. Key strengths includes emphasis on the importance of diet and lifestyle modifications, practitioners spending more time with their patients, and most practices being culturally tailored, which I understand most of you do for your practice. So some examples of the CIH interventions include dietary and herbal supplements, yoga, traditional Chinese medicine, and manual therapies, which also include acupuncture and qigong. And we'll look at a few of these before we go into the research. So when we're looking at acupuncture and herbal medicines, you can see that the general treatment principles is associated with the pathomechanisms. There are some herbal prescriptions that are very beneficial depending on the types and patterns. So you have Yunu Jian for middle Hue Ta, Hue Ta Fang for upper Hue Ta, and then you have Liu Wei Di Huang Wan if they have deficiency of yin for lower Hue Ta, or if they have yin and yang deficiency, then Shen Qigong would be a better supplement for them, herbal medicine for them. And then you see that there is some acupressure or acupuncture points commonly used for diabetes. These points are typically all over the body and on several meridians. Studies indicate that acupuncture could help regulate pancreatic function and insulin levels. So let's talk about the influence of diet from a TCM perspective. In type 2 diabetes, hyperglycemia, due to the failure of spleen transformation, is due to direct damage of the spleen by diet or emotional factors. This excessive intake of sweets or fatty foods over a long period of time will impair the spleen and the stomach, leading to impairment of the, we call it TNT, which is the transformation and transportation within the body. So being able to move things fluidly throughout the body. This impairment causes food to be retained in the body, and when combined with dryness and heat, as we mentioned earlier, will consume the fluids in the body, deplete yin, and drain the kidneys. So when we look at the Western perspective, the Western nutrition theory typically focuses on the analytical and quantitative categorization of foods. This categorization is based on material food components such as carbs, fats, proteins, vitamins, minerals, and trace elements. From the TCM perspective, we follow the qualitative, holistic concept of yin and yang, and try to illustrate how the thermal nature and flavor of the foods and medicinal herbs can actually influence the body. TCM pays a great deal of attention to proper eating. It recognizes that patients with different constitutions and problems require unique dietary solutions. The structure and content of the diet can be manipulated to help correct pathological imbalances in most instances. In all patients, the aim of diet therapy is to gradually move from whatever dietary approach is suitable to correct a particular imbalance to moving towards a balanced diet suitable for the constitution of the individual concerned. So it really depends on the pattern that we're recognizing for that particular patient. And here you can observe the varying types of recommended foods for each subtype, just to see a few. So you can see how there are some similarities, but then there's also differences depending on the pattern. Because of all of the recommendations and the plethora of research out there, it's still not known if these therapies are effective and have evidence to support their use in place or along with biomedical intervention. So that's one of the things that we're going to touch on today with some of the research that we looked at. With the growing incidence of cases of type 2 diabetes, additional support, adjunctive care may be required to overcome this epidemic as it constantly grows. So the objective of this particular presentation is to examine the current evidence of how diet and nutrition impacts the management, particularly in glycemic control for adults with type 2 diabetes. And I just want to let you guys know this is very brief because we have such a short time. So we're doing our best. So some of the search strategies you can see here, these are the following terms that I used when I was combing through the research material. We use a database available to us via SCU, which is the EBSCO, PubMed, Medline, and Google Scholar. Limited these to those published after 2011. So the inclusion criteria included full text, scholarly peer-reviewed articles, and was limited to literature reviews, systematic reviews, meta-analysis, which both actually had randomized controlled trials in there. Articles were also restricted to academic journals written or translated in the English language. So of the 42 screened, 33 were excluded because they fell within the exclusion criteria. The exclusion criteria included case studies, cohort studies, clinical studies, investigative studies, non-randomized control experiments, experimental trials, narrative reviews, and experience. Studies with incomplete data was also excluded. So then we ended up with 8 articles, primarily systematic reviews and meta-analysis. And then we kind of broke it down to the types of diets that they were looking at. So the Mediterranean diet, the low carb diet, plant-based diet, and we looked at some CAM therapies that are quite popular right now. So these are the 3 most popular diets for the management of diabetes. So let's take a look at them. So the first one is from Esposito et al. This was a systematic review, and it had 8 meta-analyses and 5 randomized controlled trials. Their aim was to summarize the evidence about the efficacy of Mediterranean diet on the management of type 2 diabetes. This study of the systematic review and meta-analysis was in compliance with the guideline PRISMA. The systematic review of all of the meta-analysis compared Mediterranean diets with a controlled diet on the treatment of type 2 diabetes. Electronic searches were carried from 2011 up to January 31st, 2015. Studies ahead of print was also included. Trials were included for meta-analysis if they had a control group treated with another diet, if there were sufficient duration, at least 6 months, and if they had at least 30 participants in each arm. And we'll look at each of these a little separately too. The random effect model was used to pool the data. So design, execution, and reporting of the included randomized controlled trials were assessed according to the Cochrane risk of bias tool. The quality of the randomized controlled trials reviewed a low risk of bias, except for blinding of participants and personnel. After initial screening of the titles and abstracts, the studies included were compared by 2 reviewers. And this was pretty prevalent in all of the research that we looked at here today. And if there was any discrepancies, they would actually have a third party, and they would talk about it with a third party. The quality of the body of evidence of each of the meta-analysis was assessed by the grade approach. The grade quality of evidence was mostly moderate in this research. Heterogeneity was assessed by using the Q statistic and the I2, which is the proportion of total variance observed between the trials attributed to the differences between trials rather than sampling error. Possible publication bias was also assessed using a contour-enhanced funnel plot. The funnel plot asymmetry was evaluated by Begg and Eager tests. All statistical analyses were performed using a Stata version 11.0 software. So for the results, 8 meta-analyses and 5 randomized controlled trials were eligible. A de novo meta-analysis of 3 long-term, which was greater than 6 months, randomized controlled trials of the Mediterranean diet and glycemic control of the type 2 diabetes was favored, and the Mediterranean diet favored the Mediterranean diet as compared to the lower fat diets. Another de novo meta-analysis of 2 long-term randomized controlled trials showed a 49% increased probability of remission of the metabolic syndrome. 5 meta-analysis showed favorable effect of the Mediterranean diet as compared to other diets on body weight, total cholesterol, and HDL-C. 2 meta-analyses demonstrated that higher adherence to the Mediterranean diet actually reduced the risk of future diabetes by 19 to 23%. So the researchers concluded that the Mediterranean diet was associated with better glycemic control and cardiovascular risk factors than control diets, included lower fat diets, suggesting that this is suitable for the overall management of type 2 diabetes. So here is a list of the trials, or the randomized control trials that was included in this study. This review did have limitations. One of the limitations relates to the low number of original trials of long duration on the Mediterranean diet and diabetes control. Moreover, consistency across these studies on the definition of Mediterranean diet varied, including the use of olive oil as the main source of dietary fat. Another possible limitation of this review includes the need to find the optimal strategies for educating individuals with type 2 diabetes and to improve adherence to the Mediterranean diet. So you guys are going to see this throughout. There's a lot of varying factors when we're looking at these studies. The next one also compared the Mediterranean diet and looked at it in terms of how it can benefit individuals with type 2 diabetes. So the meta-analysis by Hue et al. Was conducted and reported in accordance to the statement of the PRISMA to explore the effects of the Mediterranean diet on glycemic control, weight loss, and cardiovascular risk factors. They conducted a systematic electronic search using Embase, Cochrane Library, and PubMed, and they used it up to February 2014, which included randomized controlled trials that compared the Mediterranean diets with controlled diets. Effective size was estimated as mean difference with 95% confidence by using random effect methods. So 2 researchers independently assessed the eligibility of all potentially relevant studies, and any discordance in opinion was reconciled by group discussion. Risk of bias was assessed based on the Cochrane collaborations tool. Furthermore, publication bias was formally assessed by the Beggs and Eagers test. All statistical analysis was performed by means of STATA statistical software version 12.0, and a 2-sided p-value of less than 0.5 was considered statistically significant. So in regards to the results, the meta-analysis included 9 studies with 1,178 patients. They compared with control diets of Mediterranean diets led to greater reductions in HbA1c, fasting plasma glucose, fasting insulin, BMI, and body weight. Likewise, concentrations of total cholesterol and triglycerides was decreased and HDL was increased. In addition, Mediterranean diet was associated with decline of 1.45 millimeters Hg for systolic blood pressure and 1.41 mmHg for diastolic blood pressure. Let's look at the studies that they included. Just want to note that several limitations should be recognized when we're looking at this chart here. First, the Mediterranean diet is not a homogeneous pattern. If you look at the Mediterranean diet interventions, you can see the variability there. Second, control diets varied across the studies. Also, you can see here in the column that says control diets, it was also varied. And it included like the low-fat diet, the non-restricted calorie diet, the ADA diet, a high-carb diet, and regular diets. Something to note, because of the control diet, certain diets such as the low-carb diet and the American Diabetic Association diet may have beneficial effects on in terms of metabolic controls. Therefore, the effect of Mediterranean diet on glycemic control, weight loss, and cardiovascular risk factors may be underestimated. Thirdly, some evidence of publication bias was detected for the HbA1c and total cholesterol using the Eagers test. And finally, for some of the outcomes, relatively insufficient numbers of trials limited appropriate subgroup analysis. Now we're going to look at low carb. There's a few more studies for this. So the first one we're going to look at is the systematic review by Castaneda Gonzalez et al., which evaluated the effectiveness of 12 or more weeks of low carb diet compared to low fat diet, usual care diet, or the low glycemic index diet. They looked at weight reduction on A1C in type 2 diabetes individuals. A systematic review was conducted using PubMed, Cochrane, and EBS-CHO hosts from January 1st, 2000 to January 1st, 2010. It included those with an intervention program with low-carb diets in type 2 diabetes with a follow-up of greater than or equal to 12 weeks. Available data on the study design, which was a carbohydrate composition of diet, duration of diet, and the outcomes of weight, lipid levels, HbA1c percentage, and our fasting glucose were extracted. The quality of the quasi-experimental and experimental trials was assessed using the grade scale. According to these criteria, randomized trials have the highest grade of evidence score of 4, and we'll look at the grades in the next slide. Each article was independently analyzed by a researcher. Disagreements or inconsistencies on the analysis were resolved by consensus. Afterwards, a last analysis was carried out by a third investigator, resolving any remaining disagreements. So when we look at the results, 5 studies show greater reduction in low-carb diet, of which 4 demonstrated no significant difference. The longest trial intervention studies did not show a significant difference in weight change. Only 2 studies showed greater reduction of A1C with low-carb diet, including the longest intervention trial with low-carb Mediterranean diet. So it could kind of be lumped with the previous ones that we looked at earlier. So this review shows that there are no consistent differences in weight and A1C changes over long-term treatment with low-carb diet. Despite the more homogeneous content of carbs, which is less than 130 grams per day of the low-carb diet, the RCTs reviewed in the study indicated that the role of carb-restricted diets over health in the long term is yet to be investigated. The approaches to restrictions of carbs intake resulted in increase in other components of the diet, either fat or protein contents in the diets, which in the long term may be detrimental to the renal functions of individuals with diabetes, or with the LDLs or triglycerides may increase. Also, there were no evaluations on the potential adverse effects over mineral and vitamin contents of the diets, since low-carb diets may result in restricted intakes of fiber, fruit, vegetables, and dairy products. So let's look at the included randomized control trials. So when you're looking at this, there are several limitations of this systematic review. Foremost is the small number of randomized control trials available with the lesser or equal to 100 grams per day of carb intake of the diet and the intervention time greater than 12 weeks. Only 2 of the studies with an intervention greater than 12 months, and there were no studies with follow-up greater than 48 months were found. Also, the inclusions of studies with a wide range of carb content may limit the conclusion on the least amount, and that would represent a positive impact on treatment in subjects with type 2 diabetes without detrimental effects. So when you look at this and you looked at the results, they did the low-carb diet, and was quite similar, but there was some that was more, they have different categories of low-carb diet. So there's one where it's balanced, one where it's a little medium low, and then very low. And then the control group, again, was a little bit variable. They mostly looked at low-fat diet compared to low-carb diet, but there was also usual care, healthy eating diet, and low glycemic index diet. We're going to look at another one for low carb because it's very, very popular. So this one was a systematic review and meta-analysis by Meng et al. And they tried to assess the efficacy of low carb diet compared with a normal or high carb diet in patients with type 2 diabetes. They used Medline, Embase, and Cochrane library databases to search for the randomized control trials. In addition, reference lists of included studies and other potentially relevant studies were searched. There were not publication times and language restrictions for this particular study. The quality assessment of included studies was performed by the modified JDAT scale, in which the random sequence generation, concealment of allocation, double blinding, withdrawals, and dropouts were evaluated. Publication bias was assessed by visual inspection of funnel plots and eager linear regression line tests. All data was analyzed using the STAT-A version 12.0. So for the results, a total of 9 studies with 734 patients with diabetes were included. For cardiovascular risk, the pool results suggested that low-carb diet had significant effect on HbA1c. And then for the cardiovascular risk factors, the low-carb diet intervention significantly reduced triglyceride concentrations and increased HDL concentrations. But the low-carb diet was not associated with decreased levels of total cholesterol and LDL-C. Subgroup analysis indicated that short-term intervention of low-carb diet was effective for weight loss, which was something that we did not see in the previous study. But then we'll look at the differences between the two. So in conclusion, for this particular study, the results suggested a beneficial effect of low-carb diet intervention on glucose control in patients with type 2 diabetes. The low-carb diet intervention also had positive effect on triglycerides and HDL-C concentrations, but without significant effect on long-term weight loss. So let's look at the randomized control trials that they included in this study. So when you're looking at this study, they did have several limitations. Firstly, the quality scores, as you can see at the very end of the included studies, varied from low to high. Only 5 of the studies were considered as high quality. One of the primary reasons was that these studies were unlikely to use blinding and concealment of allocation. Secondly, although a patient had all received low-carb diet in this meta-analysis, it was different that carbohydrate intake ranged from 5% to 20% of daily energy from carbohydrates. And the carbohydrate content may directly lead to high heterogeneity and affect the summarized results. And you can also see here, like when they looked at low-carb diet, it looked more closer to the lower end range. And then the control group actually looked like a balanced low-carb diet when you're looking at the percentages. And we'll discuss the percentages when we compare all of them. Another research meta-analysis by Silvery et al. Assessed whether low carbs were associated with long-term improvement in glycemic control and weight loss in people with type 2 diabetes. They also looked at cardiovascular and renal safety. So it was a meta-analysis, and they looked for randomized control trials lasting more than 3 months. It was searched on PubMed, Embase, clinicaltrial.gov, Cochrane databases up to March 1st, 2020. They wanted to look for studies that compared low-carb diets and balanced carb diets in people with type 2 diabetes. When we're looking at the overall quality of evidence, here it was rated as high for HbA1c at 3 months and BMI at 6 months, moderate for HbA1c at 6 and 24 months, and BMI at 3, 12, and 24 months, and for body weight at any time point. And it was low quality for HbA1c at 12 months. And the reason why this is significant is when we're looking at the results, you'll see that they really talked about the varying differences in the months. So among the 37 trials that were received, average carb intake in low-carb diet was 36% of total energy. Low carbs were associated with significant reduction of HbA1c at 3 months, no difference at 6 to 12 months. So that's something to note. And then there was actually a significant increase at 24 months. Very low carb diets were associated with significant HbA1c reduction at 3 and 6 months, but not at all between 12 and 24 months. Low carb diets were associated with significant BMI reduction at 6 months, but not at any other time points. And only a minority of trials reported data on renal function, so renal safety could not be assessed. There were no significant differences in body weight, lipid profile, or blood pressure found in this study. The conclusion for the study was that low-carb diets may produce small short-term improvements in HbA1c and weight, which are not maintained in the long term. Data on their renal safety were insufficient. So let's look at the studies here. This is a really long chart because there was 37 randomized control trials. Okay, so just looking at this, several limitations should be considered in the interpretation of the results of this meta-analysis. Most trials are relatively small if you look at the participants list here, limiting the precision of estimates of treatment effect. In addition, most studies had a very short follow-up, which you can see in the duration on the very last column, limiting the possibility of extending results to longer-term treatments. Furthermore, many trials showed relevant methodological limitations, which introduce a possible bias. Notably, a high heterogeneity was detected for many outcomes, but the limited number of available trials did not allow a reliable discrimination of determinants of heterogeneity through subgroup analysis. Even though there was 37 randomized control trials in this meta-analysis, it still wasn't enough data for them to look at it even more specifically. So as we talk about the differences between the treatment group and the control group, a balanced diet is considered 45 to 60% of total calories from carbs. A mid-low carb diet is consistent of 26 to 45% of total calories from carbs. And then the very low is less than 26% and or less than 130 grams of carbs per day. So you can see the varying differences just with the treatment group alone, and then the control group also. Next one, we're going to look at our beloved plant-based diet. So this systematic review by Johansson et al. Aimed to evaluate the effect of plant-based diet on outcomes related to glucose metabolism. The checklist flow chart of the PRISMA guidelines were followed for this particular systematic review. The literature search was conducted in the database PubMed until January 30th, 2020. Randomized control trials investigating the effects of plant-based dietary interventions on outcomes related to glucose metabolism in humans compared to omnivorous diets were eligible for inclusion. Of the 65 publications identified, 9 trials on subjects with overweight, obesity, type 2 diabetes, and cardiovascular disease were included. So if we look at the results here, 5 studies reported that plant-based interventions significantly improved markers of glycemic control from baseline to endpoint, of which 4 reviewed a significant improvement in the intervention group compared to the control intervention on outcomes related to glucose metabolism. The remaining 4 studies did not review any significant improvements of a plant-based intervention on outcomes related to glucose metabolism. So the findings suggest that a shift to plant-based diet may lead to favorable effects on glycemic control in individuals diagnosed with type 2 diabetes and or obesity. The data were, however, somewhat conflicting, and the included trials reported results based on different intervention diets and study populations, which we'll see in the next slide. Overall, no clear conclusions regarding effects on different plant-based diets can be drawn based on the current findings alone. So we'll look at the studies that they included here. So here we want to look at the couple of strengths first. So the review has several strengths of note. None of the included studies reported a suggestive negative effect of the intervention diet, which is always a plus. All studies included followed the randomized control trial design, which is considered the gold standard for dietary intervention studies. The fact that all participants in the studies were asked to not alter their exercise patterns or physical activity levels during the intervention period is an additional strength, as exercise is known to affect both energy metabolism and nutritional status. However, there were limitations. Among the 9 studies included in this review, there were great variations in dietary patterns, as you can see in the intervention diet, the study populations, and also the criteria for exclusion and inclusion in each of these studies. The fact that most of the participant groups had a mean age between 50 to 61 years can also be considered a limitation according to comparisons to other population groups. In addition, primary and secondary outcomes differed among the studies. The plant-based diets chosen as intervention also varied. 6 of the 9 studies had vegan diets. 4 of these studies specified that the diet should be low in fat. 2 of the 3 remaining studies implemented a lacto-ovo-vegetarian diet, which was one of calorie-restricted diet. The last study that administered a low-fat plant-based diet, and the size of the study population varied between 45 participants to 291 participants. The duration intervention varied between 4 weeks to 24 weeks. Additionally, glycemic markers used for evaluation of improvement in the glycemic control also varied. So a lot of variations. So that was for the diets. Now we're going to look at a couple of the more prevalent herbal supplements that we're seeing in today's world. The systematic review and meta-analysis by Zhu et al. Aims to access the effects of ginger on type 2 diabetes. So they did an electronic literature search using PubMed, Embase, Cochrane Library, Chinese biomedical database, China National Knowledge Infrastructure, and Huafeng databases up until May 19, 2017. They looked at the data extracted as mean difference and had the 95% confidence intervals. Subgroup analysis for fasting blood glucose was performed. And for time safety, I'm just going to talk about the results and conclusions. So 10 studies met the inclusion criteria of a total of 490 individuals. Ginger actually showed a significant beneficial effect on glucose control and insulin sensitivity. The pooled weighted Mediterranean diet of HbA1c was negative 1.00. Subgroup analysis reviewed ginger obviously reduced fasting blood glucose in type 2 diabetes patients. Meanwhile, the significant effects of improvement of lipid profiles were also observed. Most analyses were not statistically heterogeneous. So the conclusion based on the negligible side effects and obvious ameliorative effects, I really like that word, on glucose control, insulin sensitivity, and lipid profile, ginger may be a promising adjunct therapy for type 2 diabetes. And then these were the studies that they included in there. So several possible limitations of the current review are worthy of comment. Firstly, although a broad search strategy was applied to minimize the publication bias, some language bias may exist due to the meta-analysis only including studies published in English or Chinese. In addition, limitations of available lits and total sample size restricted resultability. Short duration of intervention in most studies, and the significant change in BMI was limited. Therefore, better designed, adequately powered, and longer-term randomized controlled trials are still needed to explore the effects of ginger on type 2 diabetes. The other supplement we want to look at is curcumin, hot topic, very, very beneficial. So we look at the systematic review by Zhang et al., which evaluated the clinical effects of curcumin on type 2 diabetes. They used data from randomized controlled trials. The primary outcomes included the HOMA, HbA1c, total cholesterol, and triglycerides. The risk of bias was assessed based on the Cochrane Handbook. Data was analyzed by RevMan 5.3 software. The Cochrane Qs and I2 tests were used to judge the heterogeneity of different studies, and the STATA 15.0 was utilized for sensitivity analysis and publication bias detection. So 4 of the trials involving 453 participants were included. The HOMA, which is the homeostasis model assessment insulin resistance, of curcumin group is lower in Asia and Middle East subgroups. The HbA1c in the curcumin group is lower than that in the control group. The triglycerides and total cholesterol levels of the curcumin group are lower in the Asia subgroup, while in the Middle East, the difference was not of statistically significant. So based on the current evidence, curcumin may be recommended as an adjunct to improve insulin resistance, glycemic control, and reduce lipids in patients with type 2 diabetes. However, due to the lack of randomized controlled trials from all over the world, not only in Asia and the Middle East, the applicability of the findings could be limited. So here were the trials that they included. And one of the limitations, again, was because most of these trials were just taken from the Asia and the Middle East. The quality and quantity of the randomized control trials were also not high in this review. Several subgroups only included one randomized control trials. Half of the randomized control trials had unclear risk of bias in randomization, and one of the randomized control trials had high risk of bias in selective reporting, which may also influence the interpretation of the results. In addition, most of the outcomes have high heterogeneity that cannot be eliminated by the appropriate subgroup analysis, which also affects the applicability of the findings. Heterogeneity may come from potential discrepancies and pharmacological effects. So this was something very interesting that they mentioned in this study, but kind of could add that to the other studies too, right? So you want to think about, even if it's just foods, right, like vegetables and fruits, it depends on how it's processed, right? How much you're giving, the duration of the time that it's giving, if there was any, where are they receiving that type of food too. So those are things that you also have to look at when you're looking at these studies. So unfortunately for many people in the developed world, what is thought to be a good diet is often influenced by confusing and conflicting jumble of fads, fallacies, misinformation, personal bias. So I just kind of ranked it based on the quality of the research that was found. So Mediterranean diet, low carb diet, plant-based diet, and then the complementary herbs. So for Mediterranean diet, it's a generic term based on traditional eating habits in countries bordering the Mediterranean Sea. So we saw in the research studies, there was a lot of variability. The reason why there's variability, because there is not one standard of Mediterranean diet. There's at least 16 countries bordering the Mediterranean. Eating styles vary among these countries and even among regions within each country because of differences in culture, ethnic background, religion, economy, geography, and agricultural production. However, there were some common factors in these studies. They had plenty of fruits, vegetables, bread, grains, potatoes, beans, nuts, seeds, olive oils, and they also included dairy products, eggs, fish, poultry in low to moderate amounts. When we look at the low carb diets, as we discussed before, because of the variability, because you have your low carb diet, right? You have your high carb diet, you have a moderate carb diet, and then you have a very low carb diet. A lot of that is going to play into the effect of the results of the studies too. Low carb diets prioritize the glycemic loads of foods over carb count, restricting the amounts of carbs consumed while emphasizing protein and fat intake. Foods that they include very similar to Mediterranean: veggies, fruits, lean meats, eggs, legumes, lentils, fish, healthy fats, dairy products, whole grains. So those are some of the things that that were very similar to the Mediterranean diet too. And then we looked at plant-based diet. One of the things when I was kind of going over this, if you looked at the research actually wasn't for that long amount of time. So the duration was really short. And one of the things that we noticed just with lifestyle changes in itself is because the studies were so short, they really didn't find significant findings with plant-based diets. But I would like to see if there's anyone, I'm sure that there's individuals and researchers out there working on longer term studies to see if they can really find the benefits, because you hear about all of these benefits, especially with whole foods, plant-based, very beneficial for the body. And then just wanted to add the CIH interventions, the CAM interventions, all very good for adjunctive therapy. However, further research is also warranted, especially if we're looking at systematic reviews and meta-analysis. That's a lot of words. So in conclusion, although a consensus on one dietary approach in treating patients with type 2 diabetes has not been established yet, considerable progress has been made in reaching evidence-based advice. Remember, there's no one size fits all, right? This review provides evidence of beneficial effects of various dietary interventions on glycemic control, weight loss, and cardiovascular risk factors. The take-home message is that diet choice should be based on the patient's health status, tastes and preferences, including a determinations of food availability and other cultural circumstances that could affect dietary patterns. And I gave this one a whole slide because this is very, very important too when we're really talking about patients and making the recommendations for them. And lastly, here are my main recommendations. The main thing is we as healthcare providers should evaluate systemic, structural, and socioeconomic factors that may impact food choices, access to healthful foods, and dietary patterns. Optimal diabetes management requires organized, systematic approach and the involvement of a coordinated team, all of us, dedicated healthcare professionals working in an environment where patient-centered, high-quality care is a priority. And here are all the references. And then just one more thing to add. I just want to be completely transparent. I am a noob, a novice in regards to research. My patients and my very own curiosity actually sparked this review to see if I, as a practitioner, someone that went to school to know all these terms, could make some sense of this research. So any of your expert advice on how I could be a better patient advocate using evidence-based medicine is humbly welcomed and appreciated. Thank you.
Thank you so much, Dr. Ta. This was wonderful and really informative. And I want to remind everybody that's on right now that this will be up on our YouTube channel. And before we wrap up, we have a couple questions, Dr. Ta, that I will read, and then you'll be able to just kind of answer live. I'll read the first one right now. How would you support a patient with type 2 that is trying to improve their A1C without medication? Do you have any coaching or nutritional strategies?
That's a great question. One of the things that we do in TCM, I'm sure you guys do that too, just because we're at the AIHM, like having a food journal is so important. I think that's one of like the top things that we can do for our patients, right? Seeing what their habits are, especially when it comes to foods. And if there are things that we can help them with and make changes, I think that's probably the first step to see if we can help them in that aspect. I really, really recommend food journals. And living in this electronic technology world, there are so many apps out there too to log the food that you eat. And not only that, those apps have how many carbs is in those foods, how much protein, how much fat, all of those things too. So that's a great way for your patients to see what they're eating, because quality of food is so important too. Yeah, not just the numbers. It's not about how much of this, that, and the other, but it's also the quality of food.
Great. Okay, the next question is, although this is type 2 diabetes, are the same TCM patterns seen in those with type 1 diabetes and LADA?
It is similar, but there is new research out there that's looking at other types. This was just, there's only 3 patterns that I mentioned, but there's so much more, because as we know, each individual is so different. And Unfortunately, we live in a world where not everyone is only going to come to you with one issue, right? They're going to have not only type 2 diabetes, but they may actually have other comorbidities, other patterns that will kind of intermesh and intermingle. So that's more like a textbook type of pattern that we also always have to be mindful of what our patients and our clients are coming to see us for and what else they have.
Okay, and this is the last question. What about acupuncture and mind-body interventions, including MBSR, yoga, breathwork, etc.?
Oh, it's huge. I wanted to touch on that, but because like the limited amount of time, there's so much out there, especially when it comes to complementary medicine, right? There's yoga, there's Qigong, there's Tai Chi, all of those factors. I actually have a colleague who has who suffers from diabetes, unfortunately. He actually manages it with Tai Chi. So obviously he does it with nutrition, but Tai Chi is his go-to. Like he does it religiously every week with a practitioner, and that has actually helped him manage his blood glucose. Yeah, so there's lots
Great.
of good stuff out there.
Thank you. Okay, as long as there are no more questions, we just want to thank you, Dr. Ta, for this. This was wonderful. I know you had to get a lot of information in a very short amount of time. It might make sense to have a follow-up webinar to kind of go a little bit deeper. I think that would be great. And thank you everybody for joining. Again, this will be up on our YouTube channel shortly. And again, if anyone has any questions, please feel free to follow up with me or anyone on this webinar, and we'll be able to get those questions to Dr. Ta. So thank you everybody for joining.